We're going to change concepts and talk about metabolism with the exemplars of hyper and hyperthyroidism. And then we'll get to the second exemplar, osteoporosis. So let's just review and go over hypo and hyperthyroidism and how a patient manifests the symptoms and what are the causes of each. Let's talk first about hyperthyroidism. It's a pathology and etiology caused by excessive delivery of thyroid hormones. There is an increased metabolic rate, heightened sympathetic nervous system responses. Excuse me. Etiology, it could be an autoimmune stimulation where there's an excessive secretion of thyroid stimulating hormone, or TSH, and that comes from the anterior pituitary. Or it could be caused by an excessive intake of thyroid medications, which means if someone is diagnosed as being hypothyroid, there's always the chance that they take too much supplemental hormones to cause them to become hyperthyroid. Okay. The risk factors, women are more prone to hyperthyroidism, and also your genetics, and it usually occurs in the age group of 20 to 40, and also for people that intake increased iodine intake. And it makes sense, and you have to think about what the thyroid does. It's an endocrine gland. We know it sits in the neck. Produces T3 and T4 and calcitonin, and when you have an excessive secretion of thyroid hormones, these are the types of manifestations that you will see: increased appetite with weight loss, hypermotility, bowels, diarrhea, heat intolerance, insomnia, palpitations, increased sweating, hair changes, and emotional lability. This is a type of hyperthyroidism called Graves' disease. It's an autoimmune disease. Antibody in serum causes thyroid cells to hyperfunction. A person may have an enlarged thyroid gland, or what we call a goiter. And manifestations of this type of hyperthyroidism are ophthalmopathy or proptosis. And with this Graves' disease, patients experience fatigue, sleep difficulties, hand tremors, and changes in menstruation. Another type of hyperthyroidism is toxic multinodular goiter. It's a small, independently functioning nodule that secretes excessive amounts of thyroid hormones, and manifestations of hyperthyroidism develop slowly. And another type could be excessive TSH stimulation, which is an overproduction of TSH by pituitary. It's more of the rarer form. Maybe it's caused by a tumor that causes the oversecretion of that hormone from the anterior pituitary. Another type of hyperthyroidism is when thyroiditis by a viral infection, and sometimes they can happen by bacterial infections. And sometimes these acute disorders that may become chronic, especially if it's caused by a virus. A lot of times the bacterial causing the thyroiditis is just treated with antibiotics, and the symptoms then go away. Now, a thyroid storm is an excessive amount of thyroid hormones that are secreted, and it's an extreme state of hyperthyroidism, which is life-threatening. It can be caused by untreated hyperthyroidism or a very serious stressor. It's very life-threatening. There's a rapid increase in metabolic rate, and it's essential that a person who is showing a possible exhibiting of a thyroid storm should get medical attention as soon as possible. Some of the diagnostic testings that are done to determine if a patient is hyperthyroidism, a lot of it is just to verify, because many times the patients come in and complain of these unfortunate manifestations. I mean, hyperthyroidism is very difficult to live with, and these patients will not be able to tolerate it and will have to come in and say, hey, something's wrong with me. I can't sleep, my heart's beating so fast, I'm losing all this weight, my hair is, changing, I've got diarrhea all the time, and these are real serious situations, and they're going to come into their doctors and find out what's going on. They might know that it might be a thyroid problem or not know that it's thyroid, but they're going to definitely seek medical attention. And these are some of the diagnostic tests that definitely verify that they are hyperthyroid. Thyroid antibodies test, TSH test, T4, T3, T3 uptake, RAI uptake, and thyroid suppression test. And usually with TSH testing, it'll be decreased, their TSH levels. The collaboration or the treatments for hyperthyroidism are, they first try medication to suppress the secretion of thyroid hormones, but sometimes with the thyroid glands, it's enlarged, and we know where it sits in very an important area that's surrounded by the esophagus and the trachea, and some of these thyroid problems with these big goiters can really press on the esophagus, make it difficult to eat and swallow, and of course if it's pressing on the trachea, patients can have some breathing problems and respiratory issues. Thyroidectomy is sometimes the only way. It can either be partial or a full or a total thyroid removal. And with that done, remember the parathyroid glands sit within the thyroid, so you'll have to make sure that PTH is also being given to provide the hormones for those particular endocrine glands. But if they have their thyroid totally removed, say for instance a patient has cancer, they will need a lifelong hormone replacement. And how we determine is by assessment. If they have hyperthyroidism, physical assessment, muscle strength, tremors, size of the thyroid, eyes and vision, cardiovascular, peripheral vascular systems, vital signs. Many times they'll have a bruit over the thyroid, and integumentary problems, skin problems as well. Planning includes goals that may include that the patient will report an improvement, describe situations requiring contact with your provider, and if they're started on medications to inhibit the secretion of those hormones, we want to make sure that we don't put them into a hypothyroid state. So it's very important that these patients understand exactly how to take their medications and that they take them on a daily basis. Now, they're not going to immediately feel better. It may take a few weeks for those meds to kick in. So in the meantime, they may give some medications to help slow down that heart rate and, do all these other types of interventions, such as monitor blood pressure, pulse, and rhythm. They put them on a beta blocker, watch their respiratory status, suggest keeping the environment cool, free of distractions, and encourage a balance of activity with rest, because they're just in this hyper mode. Again, if they have exophthalmos, you want to monitor their visual acuity. Sometimes they have problems with photophobia. May want to teach measures for protecting the eyes, tinted glasses, shields, artificial tears, sometimes cool, moist compresses, because as that exophthalmos occurs, it pushes the eyeballs out, which makes it sometimes difficult if it's an advanced stage that the eyeballs cannot close completely. So they may want to have their eyes they're covered and tape their eyelids shut at night if they don't close. Might want to also elevate the head of the bed 45 degrees and have the patient report any pain or visual problems. Again, because they're burning calories up at a fast rate, they're losing a lot of weight, so we really want to ensure that they are receiving a balanced nutritional foods to make up for the excessive weight loss. Monitor nutritional status. We really should encourage them to weigh themselves daily and to teach about some of the dietary needs like high carbohydrate, high protein diet, and in between meal snacking. So, because like I said, these people lose an excessive amount of weight, and that metabolic rate is just so intense. improve body image, establish trusting relationship, and encourage patient to verbalize feelings. A lot of them have anxiety. A lot of them have really up and down emotions. It's a very, very difficult endocrine problem to have. Now we're looking at the other end, which is called hypothyroidism, which is a disorder that results when the thyroid gland produces insufficient amounts of thyroid hormone. And so what can cause this is thyroid hormone production decreases, thyroid gland enlarges in an attempt to produce more hormones. So you can have a goiter with both hyper and hypothyroidism. Older patients have a decrease in T4, and the comparable excessive hypothyroid state is myxedema, and you would compare that to the thyroid storm, where you have excessive hormones. This is a very hypoactive patient, which again is another life-threatening emergency. What causes hypothyroidism? It's a defect in the gland, loss of thyroid tissue, antithyroid medications, thyroiditis, endemic iodine deficiency. Secondary is pituitary TSH deficiency or peripheral resistance to TH. Medications can cause this, common in women between the ages of 30 and 60. Risk factors: women over 50 years, close relative with autoimmune condition, maybe someone who's had thyroid surgery, radiation to the neck, or an iodine deficiency. Because iodine is one of those things that you need in order to produce thyroid hormones, just like you need iron to produce red blood cells. You need iodine to produce thyroid hormones. A specific type of hypothyroidism is called Hashimoto thyroiditis. The clinical manifestations are a slow onset. Maybe a person starts to develop a goiter, or maybe they don't. They might really notice changes in their body. They might be putting on a lot of excessive weight, fluid retention and edema, decreased appetite, weight gain. They're not eating much, but they're still putting on a lot of weight. This is due to the fact that their metabolic rate has really slowed down quite alarmingly. They might start to develop constipation, dry skin, and become short of breath. These are other clinical manifestations. And abnormalities in lipid metabolism, and especially if a woman develops this after menopause, usually what we see as a correlation with hypothyroidism, we see an increase in cholesterol, and this puts that woman at a higher risk to acquire cardiovascular and heart disease. This is, like I said, comparable to the thyroid storm, but now we have a hyposecretion, a life-threatening situation where they're going from a myxedema to a myxedema coma, where they have severe metabolic disorder, can be precipitated by trauma, CNS depressants, failure to take medication, infection, exposure to cold. And this is why it's so important that patients are very, very much educated on how to take medications for both of these conditions, because this is their this has got to be done for their entire life, and without taking their medications correctly, this is the consequence that may happen: a myxedema coma, as well as if they don't take their meds to inhibit the secretion of thyroid hormones, they could go into a thyroid storm. And everything is just more excessive than it was under normal hyperthyroid conditions. Their temperatures go up so high, 105, 106 degrees, and what can actually happen to those patients with a thyroid storm is they can actually burn up their brainstem. And this is also where everything is very hypo, and this is what, and it could lead to death if patients don't seek medical attention. What they probably need is a IV injection of some thyroid hormones. Some diagnostic testings, they will do thyroid hormones T3 and T4, and obviously they'll be decreased, and TSH may be increased. If they do not respond well to medication, surgery is a possibility, especially with a large goiter. Again, do a thorough physical assessment, noting muscle strength, deep tendon reflexes, vital signs, cardiovascular and integumentary, and thyroid gland, and weight. These are some of the long-term goals. Again, when these patients start on medications, it's not like the next day all of a sudden they become fine again. It takes a while before these meds kick in, sometimes 3 to 6 weeks. So we treat the situation. We want to make sure their pulse and blood pressure, their cardiovascular status is within normal limits, and they're not exhibiting any arrhythmias. A lot of them will have bradycardia. Have skin that remains intact, warm and dry, free of edema, maintain visual acuity, and they'll have a normal heart rate and have their elimination return to normal, get their bowels back under, performing and functioning under normal conditions and not have such constipation. Again, monitor cardiac output, monitor blood pressure, apical peripheral pulses, respiratory status. These patients also feel cold all the time, so they feel like they've always got to wear a coat, and they also need to explain to the patient about frequent rest periods because they will have extreme fatigue. To prevent a lot of the constipation problems, encourage enough fluids, discuss a high-fiber diet, and increase activity as it can be tolerated. And this is about skin integrity, and this makes sense too, because sometimes the skin gets very dry and red and could be an area for skin breakdown. So that's pretty much a review of hyper and hyperthyroidism. When thinking about hyper and hyperthyroidism, this is a very serious, these are very serious endocrine disorders. And as you can see from the PowerPoint, they affect every system with the hyper as well as the hypo. With hyperthyroidism, a patient will have hypertension, tachycardia, dysrhythmias, and palpitations. Neurologically, they may have tremors of the hand and the eyes. They may be extremely nervous, suffer from insomnia, have emotional liability, and increased reflexes and very, very serious anxiety. With the integumentary system, hair loss, increased perspiration, the GI system, nausea and vomiting, diarrhea, abdominal pain. Within the reproductive system, amenorrhea, decreased fertility, decreased libido. For men, impotence, erectile dysfunction. And in the musculoskeletal system, muscle wasting, loss of strength, and fatigue. Respiratory system, dyspnea, may develop a goiter. Metabolic, hyperthermic, just always feeling hot. In the winter, they can walk outside without a coat. Diaphoresis, always feeling hungry. Severe weight loss, and fluid volume deficit, which is a very serious situation. Now, within hypothyroidism, you can still have a goiter. Respiratory problems can be dyspnea, pleural effusion within the GI system, constipation, musculoskeletal stiffness, weakness, fatigue, neurologically the hand and foot paresthesia, lethargy, somnolence, confusion, decreased reflexes, slow speech, and memory impairment. These patients may also have periorbital edema, and in the cardiovascular system, hypotension, bradycardia, dysrhythmias, can have an enlarged heart, anemia, reproductive system, menorrhagia, infertility, decreased libido. In the integumentary system, hair loss, brittle nails, coarse dry skin, and non-pitting edema. Weight gain, anorexia, and hypothermic. So those are some of the manifestations of these very serious endocrine disorders and how they affect every one of the major systems in our body. What I have here up on the screen is a example of a female who has developed hyperthyroidism. Her name is Judy Smith. She's a 55-year-old female who has recently returned to the U.S. after a lengthy missionary assignment in South Africa. She arrives at the provider's office today requesting a head-to-toe physical assessment, including a pap smear and a mammogram. Ms. Smith has has been reassigned to serve in the Fiji Islands, where health care is scarce. She would like a full workup. Her temperature is 99, her pulse is 112, respiration is 22, blood pressure 134/92. Her height is 5 foot 2 inches, and she weighs 101 pounds. In overall appearance, she's thin, older looking than her stated years, wispy gray hair and a matted bun. You note that Miss Smith has a visible goiter, and as you question her about it, she states, "Oh, I've had that for a long time. My mother had one too." She states that she's been going through the change of life for the past 5 years and is having frequent hot flashes. She has lost 10 pounds over the last few months, from which she describes as self-imposed caution when eating in third world countries. As Miss Smith is talking, you note she has a slight tremor as she pushes her hair out of her eyes. Her face is flushed and she is fanning herself throughout the interview. She is anxious and fidgets a lot, and her hair is thin and shiny, and her goiter is palpable, which has caused an enlargement of her neck. She denies sleep apnea but states that she snores. So it's obvious that she is a patient now that has hyperthyroidism, and she's got pretty much all the signs and symptoms and manifestations that we've been talking about. So think about this first question: what focused health history would be appropriate to elicit from Miss Smith? And I think as a nurse, you would want to know what country she'd been in and what diseases are prevalent in that country, what immunization she's received, or if she's had any illnesses while there. Any important health history from before she went to Africa would be very helpful. And then this next question would be, what physical assessments would you perform to obtain a complete picture of Mrs. Smith's status? Obviously, a health history would be very significant. What about her family history of thyroid disease, and when she first noticed these symptoms, and what medication she takes, and what are the significant changes in her weight and menstrual history? And then continue to assess her muscle strength, tremors, vital signs, lung sounds, heart rate and rhythm, peripheral pulses, skin condition, size of thyroid, and presence of bruit over the thyroid. And then probably you would want to draw some lab work on her to verify that she does have hyperthyroidism, which it's pretty clear cut and dry that she does. And she's in that age group, and look at, she has pulse is up, blood pressure's up. She's lost a lot of weight. She's got a goiter. Her skin looks dry and older. Her hair has changed, probably the consistency of that. She has hot flashes, which is probably due to the hyperthermia that she's experiencing. She's got the tremors. Her face is flushed, and she seems to show a lot of anxiety. And her hair is thin and shiny, So pretty evident that she has hyperthyroidism. So here's how someone may present, and not everybody presents with every sign and symptom and manifestation. Doesn't mention anything about having any exophthalmos, because she said she noticed that this. She said she's noticed that she's had that goiter for a long time. I'm surprised that somebody didn't say, "Hey, that's might be a thyroid condition," but she said she's been going through the change of life for the past 5 years, and probably that's what she accounts for her hot flashes. But everything else is just, I'm surprised that she didn't notice her heart rate going up, and that her skin was changing, her hair was changing, and the goiter really bothers me that she really didn't check that out or have a physician look at it. So there's an example of someone with hyperthyroidism. I hope it will be helpful that we go over a few questions about hyperthyroidism. So all these will be posted in Canvas if you want to use these as a review for the final on Monday. Which of the following statements made by a client would indicate to the nurse that the client understands the instructions to follow prior to a blood draw for a measurement of serum cortisol? And the answer is it would be best to have the blood drawn first thing in the morning after a good night's sleep and before breakfast and coffee. this isn't really relevant to what we're talking about. Cortisol comes again from the adrenals, but this was one of the questions within the Pearson practice questions. And here's the rationale. I'll let you read this at a later date. Question 2, which of the following methods would be preferred methods to use when performing physical assessment or palpation of the thyroid gland? There's 2 other choices on the next page. And the answer is stand behind the client, place the fingers on either side of the trachea below the thyroid cartilage, and have the patient tilt the head to the right and swallow. A lot of times they might drink water at that time. That helps them to swallow. And they'll see that the bulging of the goiter is visible when they do this assessment. And here's the, because the normal size thyroid gland is not usually palpable, okay? Okay, question 3, the nurse is assessing a patient with newly diagnosed hypothyroidism as having an enlarged thyroid gland. The nurse explains to the client that which of the following is the physiological reason for the goiter? I think this is a great question because a lot of people can't understand why you have a goiter for both problems. And here's the choices. And the answer is a compensatory effort to produce more thyroid hormone. And that's why it's very helpful to you as a student when you're learning these disease processes, that as you look at the manifestations, there is a physiological reason of why that particular manifestation is occurring. And you need to understand that rather than just memorize symptoms. Okay, why does the patient with hyperthyroidism have an increased heart rate? Why does the patient with hyperthyroidism have diarrhea? So these are things that you want to think about, because then when you understand the process and why this is occurring, then it makes it much easier that as nurses to understand why this is happening, and then why we provide the treatments that we do. Okay? Okay, now we're going to talk somewhat about the exemplar dealing with metabolism called osteoporosis. So let's go through this PowerPoint slide, and then we'll do a couple activities with pertaining to osteoporosis. Osteoporosis is a metabolic bone disorder where you have a loss of bone mass, increased bone fragility, and increased risk of fractures. Reduced bone mass is caused by imbalance in the processes that influence bone growth and maintenance, most often associated with aging and inadequate calcium intake. Estimated 57 million Americans have low bone mass or osteoporosis, and 80% are older women. 1 in 2 women and 1 in 4 men will have an osteoporosis-related fracture. Risk factors for why you would acquire osteoporosis, it obviously depends on bone mass achieved or bone mass lost, certain diseases, lifestyle habits, ethnicities. Unmodifiable risk factors are family history, age and gender, ethnicity, and other chronic diseases, and current low bone mass in children. Modifiable is female athletes, menopause, calcium deficiencies, acidosis, substance abuse, sedentary lifestyle, and medications. This is not a normal process of aging like osteoarthritis, okay? Not everybody who gets older has osteoporosis. This is how the patient appears as they develop osteoporosis: loss of height, progressive curvature of the spine, low back pain, fractures of the forearm, spine, and hip. And the collaborative care focuses on stopping or slowing down the process, alleviating the symptoms, preventing complications, and to provide proper nutrition and teach about the necessary exercise needed to prevent or slow down the process of osteoporosis. These are the ways in which we can diagnose the problem through a dual energy X-ray absorptionometry, or a DEXA, which is probably one of the most accurate ways in which we can diagnose osteoporosis. It measures bone density, in lumbar spine or hip, and it's considered highly accurate. Ultrasound of the heel to measure bone density. It's not as accurate as a DEXA. Alkaline phosphatase and serum bone GLA protein. Some of the other disciplines that may help a patient with osteoporosis is physical therapy, which is to design an appropriate exercise program, especially important for those with comorbidities such as COPD or asthma. Patients that have balance problems, it's recommended maybe some Tai Chi or yoga. And female athletes discuss amenorrhea and eating disorders. And why we say female athletes is because a lot of them, especially runners, they lose all their muscle mass, and many times these female athletes stop having menstruation occurring, and many of them could be related to not only the excessive exercise, but maybe that they've developed some eating disorders. Dietary management is choosing healthy foods, those that are high in calcium, vitamin D, and again, sources of calcium-rich foods such as dairy, vegetables, beans, enriched orange juice, breakfast cereals, and breads, and foods with vitamin D such as fish, enriched milk, cereals, and bread, and supplements of calcium and vitamin D. And again, to assess our patients to see if they're at risk for osteoporosis is age, risk factors, looking at the patient physically, their height, and any spinal curves that are noted on the assessment. Goals may include that the patient will participate in weight-bearing exercises for 30 minutes a day, 4 times a week, and have bone density evaluated every other year, get sufficient nutrition, be able to discuss risk factors, and modify home work environments to avoid injury. Because if they already have it and they fall, they're probably going to acquire a fracture. Want to prevent injury, implement safety precautions, avoid restraints on hospitalized or a long-term care patient, encourage use of assistive devices, and teach older patients about safety, fall preventions, relieve acute pain, and suggest application of heat or suggest OTC anti-inflammatories. Teach women and men through age 35 about calcium needs, encourage postmenopausal women to maintain calcium intake, and teach patients about medication use, and inform patients that calcium absorption requires sufficient levels of vitamin D. And sometimes this absorption begins to slow down, and that's why women after menopause will acquire osteoporosis. Encourage exercise, ensure safety, teach patients about weight-bearing exercise, and determine patients' interests. Plan exercise regimen in sync with their preferences, promote healthy behaviors, trying to teach them and encourage them to stop smoking, avoid or limit alcohol, and limit caffeine intake. And that's a little bit about osteoporosis. All right. Up here on the screen we have a case study involving osteoporosis. Mary Bell is a 65-year-old Caucasian female who comes to the clinic with back and hip pain. Her past medical history include COPD with intermittent steroid use, hypertension, depression, GERDs, and tobacco abuse. She lives alone, cooks for herself, and has no family living nearby and does not exercise. The nurse's observations are that Miss Bell is a frail, elderly-looking woman who is in moderate pain and moves cautiously. Her gait is unstable. What are her present modifiable and unmodifiable risk factors for osteoporosis and possible fractures? Her modifiable risk factors include disordered eating, calcium deficiency, vitamin D deficiency, substance abuse, a sedentary lifestyle, and prolonged use of some medications such as probably steroids, probably for a COPD. For Miss Bell, modifiable risk factors include smoking, use of steroids to treat COPD caused by smoking, cooking for herself that could lead to disordered eating, lack of exercise, and of course she's gone through menopause. Non-modifiable risk factors for osteoporosis would be an unknown family history of the disorder. She's 65 and she's of Caucasian race. So discuss safety risks that are present for Miss Bell. Well, she's got a lot of pain, so that puts her at risk for falls, and she lives alone. She's smoking, and cooking could be unattended. She has a history of depression. She's a frail structure, and it says that she has a very unstable gait. So what are two what further interview questions should you ask? What was your height, your maximum height? Did anyone else in your immediate family experience or have unexplained fractures? Did anybody else in your family have osteoporosis? How much milk and dairy do you consume? How much time do you spend out of doors in the sunlight? Thinking about how much vitamin D she takes in. What does she like to do for physical activity? Have you tried to quit smoking cigarettes? Do you take any dietary supplements? Do you do anything to help control this pain in your back and your hip? And have what you've done helped relieve some of the pain? And do you take any over-the-counter medications for your pain to help control that pain in your hips? So think about what are 2 nursing diagnoses for Miss Bell at that time. Obviously she is acute pain and she's a risk for injury. And then question 5, what independent nursing interventions can you perform to help make Miss Bell more comfortable and safe within the clinic? Obviously the big one is to help relieve some of this discomfort. Have her sit down in a chair that's comfortable for her and offer pillows to support her areas of pain, and maybe offer her some heat source to temporarily relieve the pain. And to help maintain her safety, we want to help her with ambulation and maybe suggest that she use a assistive device to kind of make her gait a little bit more steadier. What kind of test do you think she's going to have done when she comes in for a visit to the doctors? They'll do x-rays of her spine and hips, and they'll do that DEXA scan that we talked about on the PowerPoint, and they'll draw some blood for alkaline phosphatase. They'll do a vitamin D level and a serum bone GLA protein level. Okay. If you look at part 2, her T-score is found to be negative 3.2 in the spine and negative 3 in the hip. She continues to have pain. Miss Bell has been started on bisphosphonates. Her COPD is also exacerbated, and she's started back on steroids. When she comes back to the clinic for a follow-up, she's coughing deeply. So see what her cigarettes have done for her. They've caused her to develop COPD. What interview questions would be a priority to ask at today's visit? Just want to make sure she's continuing to take that bisphosphonates, and ask how long she's been on those steroids and how long she's been coughing, okay? And does the coughing kind of exacerbate the pain? And are you using those assisted devices that we recommend that you use so you be more steadier on your feet? And have you tried to quit smoking at this time? And have you started any weight-bearing exercises or activities? And have you tried to increase your dietary intake of calcium? And are you taking your prescribed calcium and vitamin D supplements? A lot of teaching, again, can be done to help her understand her diagnosis, especially learning about what osteoporosis is, teaching her about trying to quit smoking, to help prevent the progression of bone demineralization, how important weight-bearing exercises are, and taking her meds as ordered. What added risks related to fractures are present with Mrs. Bell's COPD exacerbation is the fact that she's got to be on those steroids. And what she is developing is a glucocorticoid-induced osteoporosis, and she could have a spontaneous bone fracture. Steroids can directly affect bone cells by slowing the rate of bone formation, and they also interfere with calcium metabolism in the body. So what type of medications can aggravate Mrs. Bell's GERD, and why? Because she does have GERD. And the most common drug class for treating osteoporosis is bisphosphonates, and these drugs are structurally analogs of pyrophosphonate, a natural substance that inhibits bone resorption. And some of the adverse reactions from these include nausea, vomiting, abdominal pain, and esophageal irritation. So this will aggravate her GERDs. And because the medication is poorly absorbed, it should be taken on an empty stomach. And so she may experience some esophageal burning after taking the medication. So you might want to educate her about that so that she doesn't take it with food, because it'll really limit how much of the medication is absorbed. Part C, she falls while out grocery shopping and is brought to the emergency room with a fracture of L3 and L4. She is admitted to the medical surgical floor for several days for conservative treatment, focusing on alleviating her pain and preventing further injury. So, what is the anticipated mortality outcome for a spine fracture versus a hip fracture? Well, vertebral fractures occur more than twice as often as hip fractures in the patient with osteoporosis. Vertebral fractures, however, have not been shown to increase client disability or mortality, but the persistent pain and associated changes in posture may restrict the patient's activities or interfere with activities of daily living. Who else might be part of helping her recover from this injury? Obviously, physical therapy, dietitian, also having people come in and assess to make sure that the home environment is safe, and things like removing all scattered rugs, remove all items from stairwells, ensure that the floor areas are well lit, and make sure that she has the use of grab bars in shower stalls or bathtubs, and maybe obtain an elevated commode seat, and instruct her to wear non-skid shoes at all times. So that is really what is important at this point. And her medications would be to continue with her prescribed bisphosphonates. She should take it immediately upon waking in the morning with a full glass of water and sitting up for 30 minutes before eating breakfast. I'm sure you've learned this in your pharmacology class. And take her calcium and vitamin D supplements as prescribed, and this will vary according to the type of calcium supplements. Lastly, so that's what we would include in patient education. And while in the hospital, Miss Bell is treated with heparin. Comment on the use of long-term heparin therapy for Miss Bell. You've had heparin in your pharmacology class, and heparin therapy increases bone resorption, and a prolonged use of heparin is associated with osteoporosis. So if she uses this for long-term, it will exacerbate her osteoporosis. Okay? So that is a situation occurring with someone who is 65 years old, and she's not very old. So, and look at all her medical problems that now have caused her to unfortunately develop osteoporosis, which is causing further problems, especially as she developed and had that injury of a fracture occur. Okay? All right, we have the second case study. It's a much shorter one, just to kind of go over and see how a patient presents with osteoporosis. This patient is a 75-year-old female who is recently widowed. She has a limited income because her husband's pension terminated when he died, and has moved in with her son, his wife, and their 3 teenage kids. Mary has cataracts and glaucoma, for which she sees an ophthalmologist on a regular basis. Otherwise, she's in good health. She goes to the community health fair with her friend. While at the fair, she has had a bone density screening performed and is told that she needs further evaluation for low bone density, a finding commonly associated with osteoporosis. In a follow-up visit with her primary care provider, Mary is told her bone scan shows evidence of decreased bone mineral density consistent with osteoporosis. She is told to increase her activity for weight-bearing exercises, to increase her calcium intake to 1,500 milligrams a day, and to take vitamin D supplement. She's also given a prescription for alendronate or Fosamax. So what kind of teaching would you provide Mary? She's told to do weight-bearing exercises like walking, and this activity will increase osteoblast growth and activity, and she'll just have to be told about her medication, the Fosamax, and its side effects, and that she needs to sit or stand for 1 hour afterwards, and she will also be told about the necessity of taking calcium and vitamin D, just like our other patient. So what outcomes are appropriate for Mary? She should do all right if she follows the regimen, and these interventions and prescriptions will hopefully help prevent fractures, okay, to increase that bone density. And what recommendations will the nurse make to reduce the risk of injury when assessing Mary's home? Again, just what we did for our other lady, removing any throw rugs, being careful around any animals, hold the rails when climbing stairs, and having furniture that is accessible and safe. So this is very similar to our other patient, except she's been prescribed Fosamax, which is helps to increase bone density or bone thickness to prevent the possibility of fractures. Okay. All right. Lastly, what we'll do is go over the practice questions for osteoporosis, and we should then conclude what we would have covered in class. Okay. So, all right. Okay, the physician prescribes alendronate or Fosamax and risdronate or Actonel for a 65-year-old female for which of the following purposes? It's funny, we just talked about this with our last patient. So how does this medication work? And the answer is 1. Inhibits osteoclastic activity and decreases the incidence of vertebral and non-vertebral fractures. These are very potent drugs that inhibit osteoclastic activity and help to decrease the incidence of vertebral and non-vertebral fractures in postmenopausal women. The actions of these drugs do not include preventing thrombus formation, binding bile acids, or acting as an anti-inflammatory agent. Question 2. A 67-year-old client asked the nurse about osteoporosis. The nurse responds that osteoporosis can be defined as, hopefully you answered 3, loss of bone density. And here's a little bit more specific information. Although all of the following nursing diagnoses are important when planning care for the patient with osteoporosis, which will the nurse select as the most significant in terms of a long-term disability? Have any ideas? The answer is 2. That's the most serious one, risk for falls. And number 4, the nurse determines that teaching goals have been met for a patient with osteoporosis when the client states, and walk 1 mile a day. We talked about that with our other patient. Weight-bearing exercises, not isometrics, help prevent bone loss. Walking is a weight-bearing exercise. It is important to maintain adequate calcium intake. When taking fluoride, smoking should be stopped altogether. Question 5. The nurse includes which of the following when teaching the patient with osteoporosis about preventive measures for complications of osteoporosis? The answer is fractures, because it's due to the calcification of bones. Infection, blood clots, and contractures are not necessarily associated with osteoporosis. Well, this concludes the discussion on hyper and hyperthyroidism and osteoporosis, and hopefully this will prepare you for your final, and I'm looking forward to the presentations on electrolytes and some of the bodily processes and solutions. Thank you for your attention, and let me know if you have any questions.